think we can start. Yeah, I think so.
Hi everyone, so we're here today. My name is Wadih and this is Perla Moussa. We're two Med1 students at Balmain University, and we have with us Dr. Naja. He's the co-founder of Lamsa and professor of psychiatry at the Faculty of Medicine at the Lebanese University, the director of Beirut Mental Health Clinic, and a part-timer consultant at the King Hussein Cancer Center.
So we're going to be talking about cancer and mental health. Basically, we know that cancer is not only a disease of the body, but it's also a disease of the mind, which is why it's very important to detect it early on and also detect the symptoms it could entail in order to be able to deal with them and manage them. This is why I have a few questions I've set for you and that I'd like to ask you.
Please.
So my first question is, how could a cancer diagnosis affect mental health, and what are the feelings that usually follow this diagnosis?
Okay, this is, first of all, thank you for your kind invitation. It's a pleasure.
Thank you for being here with us.
Pleasure in trying to diffuse some information, valuable information regarding mental health and cancer. And I'd like to thank Lamsa for the efforts they're doing in education and promotion of health in general. So it's a broad question. Yeah, I mean, any chronic disease is a stressor. And when you talk about stress in a scientific and medical perspective, we who says stress says high cortisol in the brain. Who says high cortisol in the brain, more particularly, as you know, in the hippocampus, we get more into depression or anxiety. I mean, mental health problems. So the perception, first of all, of cancer is a chronic illness. And any chronic illness has an impact via stress and cortisol on mental health. This on one hand. However, since cancer, or at least part of cancer, is an inflammatory disease, and who says an inflammatory disease, we'll also think about depression, because we know that in depression, it's an inflammatory process. So the overlap between cancer and mental health is via stress and the circuit of high cortisol in the hippocampus, so on and so forth, and the multiple areas in the brain. And you know that high cortisol can be toxic for brain cells. This is one mechanism. And the second mechanism are commonalities in the pathophysiology of cancer and mental health. Since cancer is in part inflammatory disease, and we know now, we have enough evidence to say, for instance, that mood disorders or depressive disorders are, of course, in part inflammatory disorders.
Yeah. Okay. And what would you propose would be? I'm sorry, there's a problem with the live. Apparently, they can't see us.
Oh, they can't.
But I'm not sure people are actually commenting.
Yes, we can see you.
You can't see us online.
Bonsoir, Dr. Naja. How are you?
Hello, ça va?
Ça va, vous allez bien? Oui, on vous entend et on vous voit. C'est parfait.
Okay, even through the live? Okay, we can see.
On the live as well?
Okay,
yes.
And you can hear well?
Yes, perfect. Yes.
Okay, perfect. Thank you so much.
Okay.
Thank you.
We're sorry for that. So my next question is, what would you propose would be a good coping mechanism for people that are going through a tough time mentally with cancer? Would alternative medicine be a good coping mechanism or not?
But it depends. What do you mean by tough time? What does the literature tell us? Around 40 to 60% of cancer patients will go through emotional distress. It doesn't mean the brain is sick. It doesn't mean we have a diagnosis of an anxiety disorder or a depressive or a mood disorder. It's emotional distress. So just keep this in mind that around 50% of cancer patients, 40 to 60, will go through emotional distress. Emotional distress doesn't mean disease.
Yeah.
However, when you go down, when you go further and try to look for depressive disorders or anxiety disorders, well, on average, 15 to 30% of cancer patients will suffer at one point from a depressive or an anxiety disorder. Of course, depending on the stage of the cancer, are we in palliative care? Are we in standard? Are we not into palliative care, still into regular care? The figures will be different. For instance, we have a study that we have published in 2018, out of the University on breast cancer, and the figures that we have in Lebanon concerning the breast cancer. Well, you know that when it gets to that, around 30% were currently, the population that we recruited were currently suffering from depression. But breast cancer is particularly highly linked to depression. The other types of cancer, the figure is in Lebanon. We have another paper that was published now in 2021 by the Lebanese University on cancer, mixed cancers. The figure is around 60% of depression. So to answer your question, we have to identify the problem. If we're talking about emotional distress, is family support, consulting is a psychotherapist, and if we're talking about the disorder, then you have to consider regular psychotherapy plus or minus medications. Now, regarding alternative medicine, the problem is there is no evidence-based. I mean, why not? I would say, why not? Anything is welcome to give solace and to soothe the pain, the psychological pain the patient is going through. However, unfortunately, I cannot address it. I cannot answer, give a precise answer, accurate answer regarding if we go for alternative medicine or not, because it's not evidence-based. But anything is welcome as long as we don't do harm, we try to help. Anything is welcome.
And you mentioned that depression could be caused by cancers like breast cancer. Are there other disorders that could be caused? Any disorders like OCD? Any other?
Usually, the most common conditions that you find with cancer are the mood disorders, particularly depressive disorders, and anxiety disorders. Which is, I mean, it makes sense that those are the two types of psychiatric conditions that we will come across when it gets to cancer. Of course, this is understandable. And we talk about depression, we talk also about dysthymia, which is persistent depressive disorder or chronic depression. The figure is around 5.7% in Lebanon in our study regarding mixed cancers, all types of cancers. And those figures are about 3 times higher than in the general population. Cross-sectionally, the prevalence of depression in mixed cancers in Lebanon is 16%, whereas we know it's 5% cross-section in the general population in Lebanon. So it's 3 times more. So you already have an idea that we have 3 times more mood disorders, depression, and 7 times more persistent depressive disorder in cancer compared to the general population.
Okay.
Which are pretty high figures.
Yes, yes, they are. And do you think depression could be a risk factor for cancer? Could it be a cause of cancer rather than a consequence?
Okay, there has been papers on, we haven't studied that. At the Lebanese University, we have no paper on that. We never conducted research on that. However, yes, there are papers which hint that depression might be. Well, I guess there is not enough evidence to back up this, but there are some papers in this that go in this sense, but keep in mind the commonalities in pathophysiology, the inflammatory process. Inflammatory process, I mean, is something that overlaps between depression and some anxiety disorders and of course cancer. And keep in mind also that in Lebanon, unfortunately, 70% of cancers are diagnosed in terminal stage because we don't yet have this philosophy of early detection, prevention, screening. We don't yet have it well established in our society. So unfortunately, this is why we get to those cases. This figure of 70% in terminal stage patients will come, they are already in terminal stage.
And do you think, actually, do psychiatric medication have any effects or counteractions with chemotherapy?
This is quite an interesting answer. When you say about psychiatric medication, we're talking mainly about antidepressants and anxiolytics and benzodiazepines. When it gets to antidepressants, usually with chemotherapy, I mean, chemotherapy, the drug interaction, or other medication using cancer, we should keep in mind 3 medications. Whenever it gets to antidepressants and warfarin, we have to be cautious. Usually, antidepressants are not recommended for someone who's on warfarin, or you have to be cautious when keeping an eye on the bleeding time, prosthrombic time. So we have to switch warfarin to something else as an anticoagulant, and then you can give antidepressants. And there is a concern when it gets to tamoxifen. Tamoxifen is some types of receptor positive breast cancer. When tamoxifen, yes, many antidepressants need to be avoided because of drug-drug interaction, and they will lower by 30% the efficacy of tamoxifen, which is taken usually some subcategory of cancer for around 10 years. So when you give an antidepressant, one of the best that has the least interaction is venlafaxine. So the best choice would be with tamoxifen, venlafaxine. Otherwise, we have to be cautious when it gets to diuretics and elderly patients and antidepressants because of sometimes the syndrome of inappropriate ADH secretion and hyponatremia. So it's quite easy using antidepressants with medications used in cancer is quite easy, but just keep in mind warfarin, tamoxifen, and small red flag regarding diuretics. Regarding benzodiazepines, because our patients, the cancer patients are on painkillers. Some of those painkillers have respiratory depression effect. So you have to be cautious when combining the doses of benzodiazepines with painkillers who might have a respiratory effect on respiration. Otherwise, it's very easy to combine, quite comfortable to combine.
So since we're talking about medicine, most cancer patients, because of the pain that's caused by the disease, they get painkillers. Painkillers could be morphine. Could that develop an addiction?
Yes, of course. Well, thank you for the question. Already we mentioned morphine and benzodiazepines, you have to be cautious.
Yeah.
But yes, we have, and this is why pain clinics, there are pain specialists in every cancer center who take care in managing the pain. And also there is a psychiatric profile, psychological profile, and it's something that is closely monitored to avoid, of course, the tolerance, and who says tolerance is dependence, and eventually some cases of abuse of opiates or opiate derivatives.
So now if you want to shift back a bit on the patient mental health, so we know that patients need to be educated about mental health, but it's important, how can you integrate it in the patient cancer treatment other than psychological and psychiatric support? Is there any...
Well, first of all, patients need to be screened.
Yes,
once they are diagnosed with cancer, as they are screened for any other comorbidity, mental health is a comorbidity, brain disease, so you need to screen them for a brain disease. And keep in mind one important parameter. The first 6 months, 3 to 6 months following cancer diagnosis are the most delicate. This is where you get the highest rates of suicide. Why am I mentioning that? Because suicide in cancer is twice more common than in the general population. And usually if suicide has to happen, it is, in general, the first 3 months or possibly the 6 months. So yes, to answer your question, they have to be screened as they are screened for cardiovascular diseases, as they are screened for liver diseases, liver enzymes, they have to be screened. As you do a blood test, screen them for liver function, kidney function, you have to screen them for the liver. And throughout the process of treating cancer, very often you screen them for kidney disease, for liver disease, as a side effect of medications, or for mental, but you have to keep on screening them for mental health, for brain diseases, which part of them are the psychiatric conditions. So yes, screening for mental health is mandatory from the beginning, and then regularly, and keep an eye, as we said, the first 3 to 6 months. These are delicate when it gets to suicide.
Another thing, we did not talk about the patient's family. If you have any coping mechanism that would help the patient family, friends in these hard times.
Excellent. Let me share with you 2 important data. One of them is local. What we have found in our recent paper on mixed cancers, one of the risk factors for depression, we were studying depression, we were screening depression in 300 cases of cancer, and we started the correlates. And depression in mixed cancers was correlated to lower socioeducation, which is common. I mean, it's one of the factors which is correlated with depression, but also to being isolated and lonely. So, family support, support from friends could be protective factors against depression, or at least gives him improved resilience and hopefully help him get over the emotional distress from the diagnosis and move forward and not dip from emotional distress or what we call more scientifically adjustment disorder, and not to dip into depression, to get over this adjustment disorder and move forward. Yes, family and peer support, I mean, something, social support and not being isolated are definitely protective factors.
For sure.
And again, this family support also will help for suicide. We'll talk about this later on also. But at least, yes, family support is detrimental.
What are some organizations here in Lebanon where the cancer patient family support and friends can go to ask for advice?
Many organizations, many NGOs are available. They provide care, they provide support, they palliative, intermediate, at any level. There are many NGOs who are involved, and
if you can state two now, in case someone.
I don't have the names in mind, but I can look them for you, and you can publish them on your website. Yes, there are multiple organizations.
One question about cannabis. We've heard a lot about medical cannabis for cancer patients. If you have any thoughts about it, and what do you think? How does it help?
Okay. The problem of medical cannabis, you have already a big palette of medications which are available. And when you say medical cannabis, you have to make sure that we're talking about medical cannabis. What does it mean? What is medical cannabis? It is the refined cannabis. It's not the cannabis, it's not the straight cannabis. It has to be refined into cannabidiol and take away the tetrahydrocannabinol. The problem is, when you talk about cannabis in cancer, unfortunately, one of those key messages, erroneous messages, is that go smoke cannabis. Okay, it has to be refined.
Yeah, sure.
Number two, there are so many, the palette of medications is so huge, so you don't need to get there. And number three, not much evidence. So the problem of medicinal cannabis in general, you could say at one point it could be a hoax. It can have been hyped because we already have pharmacological agents who are less expensive, who do the same job and even better, and not to get there with much more evidence.
Our last question is about the actual economic situation in Lebanon. Do you think that the shortage of cancer medication experienced in Lebanon could be a risk factor for worsening psychiatric disorders?
Excellent question. One of the risk factors correlated with depression in the mixed cancer study that we have found published this year was absence of insurance, which means medical insurance, which means those needy people who don't get appropriate coverage are more at risk of a mental condition, depression. And in our breast cancer study in 2018, again, we found that lack of insurance was correlated to depression in breast cancer women. So here again, you can see that, can perceive that low economic status and financial burden will add to the burden of cancer and mental health. And mind you, irrespective of, let's dismiss cancer. Low economic status, financial distress is already by itself a stressful life event that promotes anxiety disorders, promotes depression. So it won't be a surprise that those cancer patients already have to fight for the condition. Having this shortage of medication, shortage in coverage of the appropriate medical care, of course.
I would like to add a question. You've mentioned lots of correlation between depression and breast cancer, but isn't breast cancer one of the cancers with better prognosis?
Yes, but okay, depression is correlated to all types of cancers, mixed cancers, but it's in particular to breast cancer. And this is the figure that we had in Lebanon has been replicated worldwide. It's not a matter of our society. Well, probably why? Why would it be? Because think about it this way. Look how stressful breast cancer is for a lady. Let's look at it. Number one, what is she losing?
Yeah.
Her breasts. What are the breasts? They are the hallmark of femininity, of the image. Number two, she's sick, she's young, she will fail as a mother in providing care and taking care of her children because she's being treated for cancer. Number three, marital problems. Number four, the guilt that she might be genetically giving cancer to her children, to her good daughters. So there are so many factors, stressful factors regarding the breast cancer, probably promoting higher rates of depression in breast cancer patients. The guilt of this genetic guilt. I might be responsible for a cancer that will hurt my daughter at one point, my daughters at one point.
Okay, these are the questions I have. Thank you so much for joining us. If you'd like to add anything, feel free, please.
Well, I mean patients need to be family support.
Yeah.
The key message is number one, family support is detrimental and crucial and helps a lot of our patients. Number two, all patients should be screened as they are screened for other conditions. And most importantly, they have to be screened mainly the first 3 to 6 months. This is where the burden of the diagnosis of cancer, the mental burden of the diagnosis of cancer is at its climax. This is where you need to be very cautious with patients. Number four, psychotherapy is a very important tool. Cognitive behavioral psychotherapy is a very important tool, as important as antidepressants, if not even more important than antidepressants. And number five, if you're comfortable with antidepressants, keeping in mind caution with warfarin, tamoxifen, and small red flag when it gets to diuretics and elderly patients. Otherwise, feel comfortable to treat them. It's a chronic disease and it's a lethal disease.
Yeah.
So as chronic diseases promote depression, we're dealing with a chronic, potentially lethal condition.
Yes. Okay. Thank you so much.
Thank you so much.
Thank you so much for joining us and for your time. And thank you everyone for joining us as well. We hope you enjoyed it. Yeah. Bye.